Hi, everyone. We're just going to give it a little bit longer before we get started to give people a little bit more time to join. All right, hello and welcome to the webinar, Scans in Ovarian Cancer, Everything You Want to Know. I'm Maggie Nicholas-Alexander, the Senior Director of Gynecologic Cancer Patient Support and Education at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. We have a few housekeeping reminders for you. All participants will be muted during the presentation. Once the speakers finish presenting, we'll begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember, the speakers are unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. This webinar is being recorded. We'll be sharing the recording in a few weeks with all registrants, and it will also be added to our website. Now, I'm so excited to hand it over to today's speakers who feel so appreciative that they're joining us today. So I'll hand it over to Dr. Holcomb.
Thanks so much, Maggie. Welcome, everyone, and good evening. I want to thank SHARE for another opportunity to address the community. And I love the topic choice here of scans, because I think any practicing GYN oncologist knows that this is an area of confusion very often. And so I think it's a great opportunity for SHARE to make you guys more familiar with how we think about things and work together with our radiology colleagues to try to deliver the highest level of care. I'm a gynecologic oncologist. I work at Weill Cornell Medical Center in NewYork-Presbyterian Hospital here in New York City. I was the prior director of the division here of GYN Onc. I'm currently the vice chair of oncology in the department, and I'm also the associate dean of admissions in the medical school. But I still practice. I have a pretty active clinical practice, and I brought along my colleague, Dr. Elisabeth O'Dwyer, who also practices here at Weill Cornell, so I'll let her introduce herself.
Hi, my name is Elisabeth O'Dwyer. So as Dr. Holcomb said, I'm a radiologist in Weill Cornell Imaging and also in NewYork-Presbyterian. I work in the divisions of body oncology and molecular imaging, and I have a special interest in gynae imaging, and I work on the gynae DMT with Dr. Holcomb and his colleagues. So I'm excited, and thank you, Cher, for inviting me to talk to the community regarding scans, because I think it can be quite a complex thing. There's lots of different ones, so hopefully at the end of this, people have a better idea of the different things that we offer and why we offer them, and maybe answer some questions and concerns that they may have about it, and show how we use it and how we work together with our colleagues in gyn-onc and radiation oncology about offering you guys the best possible treatment pathway and hopefully cure for the vast majority of you.
Great, thank you so much. So we'll hand it over to both of you to get started with today's presentation.
Sure. And we'll take a minute just to get our slides up. I think my experience with the SHARE community is that it tends to be a pretty knowledgeable community. So I want to jump straight in without reviewing the epidemiology of ovarian cancers and the presentation and symptoms, things like that, and go straight into the meat of the topic. And I think what makes it complex, as Dr. O'Dwyer mentioned about the role of scans in ovarian cancer, is that the role is totally dependent on the point in time or your journey in the ovarian cancer treatment journey. Because it extends all the way from evaluation of someone with an adnexal mass, an ovarian mass or a pelvic mass, or even someone with non-specific symptoms that might make you think they have ovarian cancer. There's a role of radiology in screening. It's limited, but we can talk about that. Women who you think have early stage disease, women who have advanced stage disease, monitoring the response to treatment when people are on systemic therapy, and then the detection of recurrence. There's even a role for radiology and maybe determining who you might operate on in the setting of a recurrence. And so all of these different situations have different tests that we tend to use for different reasons. So we're going to go through our thought process and why we choose those at those different times. Next slide, please.
Oh, sorry.
Okay, so we're going to start off the conversation, and you'll see Dr. O'Dwyer has the heavy lifting to do in this talk, because she's going to be really going into the differences of the modalities. But we'll start off with the beginning for most people, and that's the use of radiology and detection of early stage ovarian cancer. And this is usually on my part, someone who's being referred to me because they either have a symptom, and the symptoms of ovarian cancer can be very vague and non-specific, or we already know they have a mass in their pelvis, an ovarian or a tubal or just a pelvic mass. And that's a specific situation. As you all know, there's no routine recommendation for screening general population for ovarian cancer because of the limitations of the screening modalities. But there is a role of screening for high-risk individuals. So these are women with genetic predispositions or higher risks of cancer. Okay. I don't know if I should be going into answering things into the chat. I guess we should wait and maybe collect those in the end. So Stacey, I see your question there, but I guess we'll come back to it. Next slide. Yeah,
so I suppose the next question is, how do we investigate these two buckets? So like predominantly if somebody's symptomatic or there's a suspicion of an adnexal mass, either on clinical examination or on another modality such as CT. So our two mainstays that we use are both ultrasound and MRI with pelvis with contrast. So I'm just going to talk a little bit about both of those. So on the left is just an image of an ultrasound, and on the right is an image of an MRI. So ultrasound. So ultrasound, many of you may have had. It's pretty commonly available. It's pretty easy access. We do it with the transabdominal. So that's looking using a probe such as this one here, where we put jelly on the probe and place it on the woman's abdomen. Usually we ask you to have a full bladder for that, not just because it gives us better visualization of the uterus itself and the ovaries. And then we also typically like to do a transvaginal, or sometimes you can see it in reports called endovaginal. And that's where we put the probe in the vagina, and then it allows us to get better visualization of the uterus, the cervix, and the ovaries. So that's usually done with a smaller probe like this probe here. It's done under a sterile, it's cleaned, it's done, it's, there's a cover over it. So it's a very sterile process, but it gives us very good information. Some of you might ask, well, why don't we just do that one alone or just do this one alone? They can be additive, especially because the ovaries are on the fallopian tube and they can be actually pretty mobile in the pelvis. So sometimes they can be seen here, but sometimes they're up here. So if they're up here, the transvaginal ultrasound may not be helpful for that, and the transabdominal may be useful. So together they're additive. We're obsessed with menopausal status and last menstrual period. during radiology examinations for a number of reasons, but for ultrasound, especially for ovarian imaging, this can be very important because in premenopausal women, because you're ovulating, there can be certain physiological or benign entities that can happen because of that and can give us some really good information. So that's why we ask you that question. And then additionally, as I said, we'd like you to have a full bladder for a transabdominal, and then for a transvaginal ultrasound, we'd like you to empty your bladder and have it gives us better images. And then it's got no radiation. This is a very safe study, no radiation. Most patients don't find it painful. The endovaginal, the transvaginal component can be a little bit discomfort for people, but much less so than a pap smear or anything like that. So it's usually well tolerated. And this when we get 2D images like I showed previously. So this is really the mainstay of on our first step and our first line of how we can identify most ovarian or adnexal masses. Most patients, we can get pretty good images with this. We can characterize whether the mass has suspicious features, which I'll discuss in a little bit. And we don't really need to do any further imaging. Based on the appearance of this, we can speak to our colleagues in Gyn-Onc, and then they can either plan for surgery or following them as such. Occasionally, we don't get a very good image. We would like some more images. We'd like to characterize it a little bit further. And if that's the case, then an MRI can be very helpful. So this is a picture of an MRI with a big mass seen within the left ovary. So you might be like, your arrows on the right side of the image. Radiology, we look at everything kind of inversely. It's kind of slightly obtuse, but that's just the way it is. So just if I'm saying left and I'm pointing at the right hand side of your screen, that's just to orientate people. So this is a great study for pelvic imaging because we have really good soft tissue contrast, so we can get really good ideas of what's going on with the mass. But there is some issues and why we don't offer it to everyone. It's a much longer study than a ultrasound, and often doesn't give us any additional information than what we would get with an ultrasound. The advantages are it does have 3D images. Similarly to an ultrasound, it offers no radiation, but it is a large magnet. So this is a big magnet, and then it creates our images using that magnetic force. And that's kind of important because when it's a big magnet, metal things can get attracted to it. So this is an image that was published in the New York Times in 2017 of an office chair that was attracted into the magnet. So this can be kind of dangerous, and this is important because not every patient can get it. So patients with certain type of pacemakers may not be suitable for it, cochlear implants. So it's a much more involved study. It's also much longer compared to a ultrasound, and some patients don't like it because it's quite a noisy examination, although they're less noisy with neuroscanners, and also can be a little bit claustrophobic for all patients. And most importantly, it isn't always necessary. We can get a lot of really good information with ultrasound. So if you're not offered an MRI, your standard of care isn't any different. It may be just that it's not needed in your situation. So suspicious features, when we're looking at both an ultrasound, and this is actually the same image. These are the images I showed you earlier about an MRI and an ultrasound. So what we're looking for is suspicious features, and what we think of as suspicious features are things with solid masses, kind of solid components which have blood supply, which is shown here with this color image. And then if they have associated features, so enlarged lymph nodes, fluid in the pelvis or nodules in the pelvis, they're all very suspicious looking features. So that's what we're looking for on both a MRI and an ultrasound. And I hope that for some of the audience, you can appreciate that although it is a complex thing, that this ultrasound also gives us pretty good information, and the MRI wasn't hugely additive in this setting. So just to reassure you that if you're not offered an MRI, that isn't always a bad thing. Okay. Oh, sorry, and that was just an image to show you that not always, this is just talking about menopausal status. So this is in a premenopausal woman, and this is actually a benign lesion. So although it has like solid components within it, it's very classic for something called a corpus luteum, which I'll mention in a little bit. And this is just represents that you've had a recent ovulation. So that's why it's just important that we like to know a little bit of information about patients, just because it allows us to contextualize things. So as Dr. Holcomb had mentioned previously, screening is not recommended in the general population, but is recommended in patients with high risk groups. So namely BRCA1 and BRCA2 genetic mutations, For that, the recommendation is that we should do it predominantly with ultrasound and serial CA125. So that is the recommendation, not even MRI in those population.
Dr. O'Dwyer, there's a number of questions in the chat that I think I can sort of address with one thing, because I think a lot of people are confused. Well, if you have this sonogram that's low cost, doesn't have radiation, why not just offer it to everybody as a screening tool? And I think what's important to know is that the definition of success of a screening tool is not just that you can detect the cancer with it, but that you can detect the cancer with it at an earlier stage and be able to show an improvement in survival in that population that had that screening test compared to a group that didn't have the screen. And although intuitively, I have a hard time understanding how a sonogram wouldn't help, it has been shown over and over and over not to have sufficient sensitivity or specificity. You can't specifically say what's cancer and what's benign. And repeatedly in the United States, UK, and different settings, we've seen that it doesn't decrease mortality from ovarian cancer and actually can lead to unnecessary surgeries with their subsequent risk of complications. So I just wanted to put that out there, that it's not a matter of cost, it's a matter of a lack of efficacy. And
then maybe just, I know I'll be touching on this briefly, it also is, apart from morbidity and morbidity attached to surgeries, there's also a certain cost to the patient of repeated investigations and following of things that are actually benign. There's an anxiety attached with that. And if we haven't proven benefit and survival benefit, it's hard to recommend that we would routinely ask somebody to do an ultrasound, which may lead to them having 10 more ultrasounds or other investigations because of that. So, and this kind of leans on this point, but like in the vast majority of premenopausal women, the majority of ovarian lesions that we see are physiological and benign. So you see reports, you may see certain terminology like follicle or dominant follicle, corpus luteum, a physiological or functional cyst, endometriomas, dermoids, and hemorrhagic cysts. And these are all benign entities. But if we had people routinely in screening programs, there would be a certain percentage of people that would end up getting followed for these certain things just because of inexperience of the screener or patient anxiety. And I think we're trying not to over medicalize an asymptomatic population. It's really important that we try to offer screening in a population that we're shown to have intervention in and that we make a difference in, and not over medicalize well people. Because I think that there's a certain anxiety, a scan anxiety that can happen when we over medicalize well people. So just touching briefly on this, ORADs, or the Ovarian Index Reported Data System. Some of you may have seen this score system in your reports. It's not routinely used. It's been developed by the American College of Radiology. And it's just a way just to standardize our descriptors of adnexal lesions, just so we can have better communication with both our colleagues in gynecology, and also to improve that we make sure we look after the right patients. So this may be something that you guys see more in your ultrasound and MRI reports going forward. But it's basically just a way to concise the information that I've mentioned previously about the risk factors and the lesions that aren't suspicious. So
if you have a suspicious symptom or you've had imaging and there's a concerning finding on an ultrasound or MRI, what's next? Well, the gynecologic oncologist is going to typically perform some serum tumor markers. And again, CA125 is going to be one of the most common we get. And that's different than using it as a screen. A screen is a test you give to someone who has no symptoms and no reason of getting this test other than the fact that it's just time for their screen. Whereas this is using it to evaluate an adnexal mass. In the end, you're going to need some tissue. You're going to need a histologic confirmation by a pathologist to say this is either benign or it's malignant. That may come in the form of a laparoscopic procedure and removing the mass. That may come as a CT-guided biopsy if further imaging shows disease in other places. But in the end, the next step is going to be removing that mass or biopsying something that is suspicious for metastatic disease. Next slide. So we as G1 oncologists and general gynecologists are often the first ones operating on somebody in this situation. And when you have somebody that has this suspicious pelvic mass, there's really three goals to the original surgery. One, and the most important, is that you have to make a diagnosis. Dr. O'Dwyer showed you all the benign things that can present as a worrisome cancer. So getting the mass out to a pathologist is going to be really important. The next thing is staging. If you look around the abdomen and you see no evidence of gross metastatic disease, there's nothing in the upper abdomen, you just can't assume that it's stage 1. If in fact the biopsy comes back that it's a cancer, ovarian cancer is staged surgically, because you can have microscopic disease in some areas that affect the risk of recurrence. It affects our recommendations to patients as far as post-operative treatments. And what we've seen is that if you don't do this comprehensive staging, you'll understage and potentially hold back on with potentially life-saving treatment in a number of those women. So that's the other issue. In somebody who you either at the time of surgery or on a CAT scan beforehand, you see that they have metastatic disease. Yes, you want to establish a diagnosis because you can have metastatic disease from other sites that mimic an ovarian cancer. But at that point, what's also important is this concept of surgical debulking. Sometimes you hear it called cytoreductive surgery. And it's something that's pretty specific to ovarian cancer. Next slide. This concept that removing as much tumor as you can before moving on to chemotherapy and showing a survival benefit from doing so is something that has been shown consistently from the early days of ovarian cancer research in the 1980s, where researchers at this times went back and looked and saw how long did people survive when they had completely debulked, the tumors were removed, or they were down to very small residual nodules, and when they were unable to achieve that. And you see the wide range of survival from study to study, but they all show the same thing. The trend is that patients who you can get optimally debulked benefit from that effort. Next slide. But what we know now is that it doesn't seem to matter when you get optimally debulked. It's important to get optimally debulked during your primary treatment, but there's two ways to achieve that. There's one way where it's called primary debulking surgery, where you're going to have surgery first, and I'm talking about women with advanced ovarian cancers, and you remove all the tumor you can, and then you give adjuvant chemotherapy. That was the traditional way to approach advanced ovarian cancer. There were always some patients who were too sick for surgery or really had such advanced disease that you were really sure you couldn't get them optimally debulked. And in those patients, we use option 2, which is called neoadjuvant chemotherapy, meaning that it's something done before the surgery. So in that case, the surgery is not done up front. It's actually sandwiched in between the chemotherapy. So in option 1, you're getting 6 cycles after the surgery. In option 2, neoadjuvant, you're getting 3 cycles on either side of the surgery. Next slide. What we know now about neoadjuvant chemotherapy is that even though we typically used to use it only in women who had really poor candidates for surgery because of medical reasons, a number of studies, this is one of the first ones that was published in the New England Journal of Medicine in 2010, have shown that women who are debulked primarily and then given chemo, which if you look at that top slide, and women who get neoadjuvant chemo have almost exactly the same outcome, so that it doesn't appear to matter. And there was a lot of controversy about this study. Okay, next slide. It was actually done again. Both of these European studies, large studies, this one in 2015, same thing, a comparison of neoadjuvant chemotherapy and primary debulking surgery. And they found the same thing in this study. This was called the Chorus study. And you don't have to be a statistician to see those two curves are the same. And so Dr. O'Dwyer is going to get into a little bit about the role of radiology in helping us manage patients who are presenting with advanced stage ovarian cancer, to help us make this decision over who can be debulked and who can't up front. Next slide. You can pass that one.
Okay, so as Dr. Holcomb said, it's important, debulking is important for long-term survival, but that time is just a little bit, can be variable in patients and practitioners. So I think the main thing that we use for staging and how radiology can be helpful in this fashion is that we can perform CT at this point. And we're not looking at the CT to primarily look at the tumor, because sometimes the tumor is already out, as mentioned. But what we're looking for is disease outside of the tumor, the ovarian tumor itself. So cancer within lymph nodes or cancer in sites outside of the pelvis. So be it the liver, lungs, or probably the most important one and where we can be kind of helpful for is the peritoneum. So this is like this lining of the stomach that goes all the way around the stomach and lines lots of organs. And unfortunately, with ovarian cancer, it's a very common location for metastatic disease. So in cases like this, we have a lot of fluid here, which is a secondary sign of peritoneal disease. And then we have this kind of lumpy, bumpy area, which should normally be black like this, just representing fat. And this is suspicious for peritoneal disease. So CT is validated as an accurate imaging method to predict successful surgical cytoreduction. And that's because we can be quite helpful for when we see tumors greater than 1 centimeter for identifying peritoneal disease. We're not as good with tumor size less than 1 centimeter, and that's why laparoscopic staging is still so important. But we can be very helpful in showing which patients probably have a higher risk of having more widespread disease than others. And there was 2 big trials. There's a trial out of Europe, and then there's a trial out of America, which was centered in predominantly Memorial Sloan Kettering and MD Anderson in Texas. 2 big cancer hospitals in the US. And both of these showed similarly that it has very good sensitivity, about 70% sensitivity and specificity compared to for what they saw at surgery. And then this US trial also showed kind of a scoring system and a way for us to be predicting it. So it's something that we keep in mind when we're reading cases of patients for staging, and hopefully can be helpful for our surgeons if you do that neoadjuvant approach first, that they have a better idea of where tumor is likely to be and how aggressive they need to be with their debulking. So this is just an arrow showing you this. And as I said, we're very good at centimeter, probably less than 5 millimeters. We're less good, and that's because of the integral limitations of CT. So CT is, we take slices which typically are about 3 millimeters of a difference between each slice. So deposits that are less than 5 millimeters can often be missed in those small slices. So it's not, perfect. So I'm just going to talk a little bit about CT. So when is a CT indicated? So as we mentioned previously, staging, and then it also is an integral for treatment response, and also in the case of a suspected recurrence. So it's unlike ultrasound and MRI, which I spoke about earlier. CT is slightly different. It does have radiation, so it is there is a radiation exposure with this test. But it's a pretty quick test. It's very useful. It gives us a lot of information. We typically in ovarian cancer patients do a CT chest, abdomen, and pelvis. And CT chest is superior over any other modality, ultrasound or MRI, for evaluation of chest and lung findings. So it's helpful in that situation. This image just below is to show you why we typically do it with iodinated contrast. So sometimes I think patients are a little bit worried about iodinated contrast, and often are asking why they don't have to do it. And this image is just to show that this is a non-contrast CT. So they drank oral contrast, but we didn't inject them with IV contrast like we did in this study, because you can see this is their aorta, which is the main artery supply in the abdomen. And this is bright because we've given them contrast. And we can see here the liver looks pretty normal. We have fluid, which is suggestive of peritoneal disease. But when we gave them contrast, we get better conspicuity and better information in the liver. And we can see these 2 little small lesions, which unfortunately turned out to be liver mets. So that is why us as radiologists are obsessed with contrast and love contrast, because it really makes our life so much easier and often can pick up disease at a much earlier stage, rather than pick up sub-centimeter lesions, which often would be missed on non-contrast studies. So contrast can be a little bit worrying for patients because we have a lot of questions that go around with it. So iodinated contrast allergies are real and are important, and there is we have to take those seriously. But things that we come across regularly is seafood or shellfish allergies are not cross-contaminated. There's no association with them with iodinated contrast allergies. So that's something that we don't need to be worried about. And you don't require pre-medication for it. If you do truly have a iodinated contrast allergy, that can be variable, and there's different. That can be something as little as feeling like kind of an itch afterwards, or feeling a little bit warm, or heart rate going up. And for that, we typically recommend that you would be pre-medicated for those studies, but it shouldn't preclude you having the test. Typically, most patients, if they're in an appropriate setting, so we would schedule in the main hospital where there's a lot more secondary support, most patients can tolerate iodinated contrast if they have appropriate pre-medication and it's in an appropriate medical setting. Of course, there's some extreme examples where people have had anaphylactic events and serious life-threatening events, and for those patients we would choose not to give them contrast, and we may recommend a different test. But overall, it's pretty good. Radiation-wise, the radiation exposure through new technology, which has been around for the last 15 years or so, has meant that we can really reduce down the dose. So the dose for each CT is probably about 4 times what you get from background radiation. So that's just radiation of living your life in New York City or wherever you are in the world. There's always a small amount of radiation. So it's not, we don't want to be doing them to every day of the week on you, or even every week or every month. Unless it's indicated, but the radiation dose is significantly lower than it was in the early 90s when it was a real concern. And then from a technology point of view, contrast is we love contrast. We often will ask you to drink oral contrast too, and that's because that can be helpful for picking up this peritoneal disease, which can sometimes happen along the bowel. So it can be helpful. So that would be our preference, would be oral and enteric contrast, because it makes us easier at detecting disease at an earlier stage. So, Dr. Holcomb.
Sure. So, as many of you know, once we have a diagnosis of ovarian cancer, and if it's an advanced stage or a high-risk early stage, we're going to give first-line chemotherapy. And although there have been so many advances in the treatment of ovarian cancer, real important improvements. Interestingly, that frontline status of platinum has not been changed. Platinum remains the most active agent in ovarian cancer. And it's just something about that tumor. It's at least initially, it's very sensitive to chemotherapy. And so we achieve a remission in the majority of patients who present with advanced stage disease, who have a debulking surgery and receive platinum-based chemotherapy. And I think our struggle really is in recurrence. And I just want to address, I think that term recurrence is very misleading in that it gives someone the idea that the tumor came back from nowhere, but recurrence is really just residual disease. It may have been microscopic at the completion of your therapy and not picked up on imaging and a normal blood test and a normal physical exam, and yet it was still there, and you don't find out about it until later. Next slide.
Yeah, so imaging on systemic therapy, similar to that imaging for staging, is typically a contrast-enhanced CT. Occasionally, we will use PET-CT or MRI to help kind of tease out maybe some findings that we would see on CT, but the mainstay is again CT. And what we're looking for here is we're trying to make sure that the pelvis looks like it should do, what we would expect it to look like after a hysterectomy and bilateral sompnomphorectomy. And then we're also trying to see if they do have residual disease, whether the residual disease is getting smaller or disappearing, which is what we would hope to see. So conventional therapies, as Dr. Holcomb has mentioned, is typically this platinum chemotherapy, but certain patients, when they're on, they've maybe gone through that chemotherapy and progressed on that, they may be put on certain different therapies, such as targeted therapies. And that's just important just to touch on briefly, because they're not like classic chemotherapy. They don't try to kill off the cells like classic chemotherapy does. So they can have a slightly different response pattern to what we would expect for chemotherapy. So often They won't change in size over a number of scans. They may have different, they may change in the density they appear on our CT. So they may appear slightly less solid, but the size may not change. And those are all still very good prognostic markers that the targeted therapy is working. So sometimes we have to let things work through and see, like, time is also very helpful for us to see about progression or not. And that kind of just like is just a touch on from a clinical and a point of view, we don't really typically use these terms, but in a study setting, we're looking for, we would sometimes think about things as being a complete response where all the disease goes away, partial response where some things go away and some things don't really go away, or even sometimes stable disease where things just stay the same. And that really typically can happen a lot with these targeted therapies. So it can be discouraging to see your reports and see things that haven't really changed, but that does not mean that things are not working. It just may be that they're not, sometimes the imaging is much slower than the appearances on imaging can be slower and can lag behind what actually is happening at a microscopic level. So that's something just to be aware of, and just that it's important not to just be solely fixated on numbers, because sometimes things can change and that can still be a very good sign that things aren't progressing. So when can FGG PET? So this is PET CT. So, when do we use PET and when is it helpful? So it's useful in certain circumstances. So this is for people who haven't seen it, this is a PET CT. So PET CT is very different than the prior studies that we have talked about. So unlike ultrasound or MRI, it does have radiation, and it's typically we combine it with a CT or an MRI, which is done at the same time. But unlike this, just a CT on its own, the patient, so you, would be injected with a radioactive glucose injection. So it's and why we do that is because cancer cells have been shown to use more glucose than normal cells. So by injecting them with, when we label them with radiation, we can then image that and we can see which are metabolically active cancer cells. And this can be really helpful in just to delineate kind of small focuses of tumor, and also can give us a good idea about, especially in the setting of sometimes these targeted therapies, if they haven't decreased in size, sometimes we can see that they've become metabolically inactive, which is a good marker for the fact that they're not active, or the therapy is working. So this typically is done with a CT, but it can be done in certain centers with an MRI, which honestly, isn't always necessarily better. MRI isn't better. So in the vast majority of patients, CT is appropriate. The radiation dose is a little bit more than just a conventional CT. It's a little bit more, so hence why we don't do it for every patient. And also it's not very helpful in every patient. So although certain ovarian cancers do like eating up these glucose cells, some don't. So certain cancers like mucinous ovarian cancer often is not very avid on a PET CT, and it may not be very helpful because just of the integral components of that cancer and how it's made up. And then, yeah, that's basically, I think it's very helpful in the setting of certain recurrent cases. I don't think, and there hasn't been any studies shown in the literature to show it's a huge benefit in the primary staging setting. So I think it's pretty helpful in the setting of staging, and has been really, and we'll show a good example, hopefully with time at the end, where it's been really beneficial. But it's nuanced, and it's not something that we offer to every patient because it doesn't offer benefit to every patient. And the radiation dose, although is not horrendous, is not inconsequential. So we want to limit it if it isn't necessary.
Dr. O'Dwyer, could you speak a little bit about the quality of the CT scan?
Yes, I did need to talk about that. So yes, so the CT that we do for this study, and even the PET, if we do an MRI with it, these aren't what we call quote unquote diagnostic CTs. So we're using them predominantly for localization. So I should have shown a picture. Typically, if you're just looking at a normal non-fused PET, which we see here, it's a very kind of grainy black and white image. And that's how they originally read PET. But it was kind of hard to localize where this activity was. So we got the good idea of combining the CT with the PET. So it allows us to say, oh, this activity is within the anterior stomach, as opposed to it potentially being in the middle of the stomach. So the CT is predominantly being designed for anatomical localization and is not a diagnostic CT like you would get for a CT abdomen and pelvis, which we give with contrast. We don't typically give IV contrast with these studies because it's not a diagnostic study. So we're not doing it for timing purposes. So although the CT can be helpful for identifying it, it's not a surrogate for, or does not replace a normal diagnostic CT. So suspected recurrence, I think, is really the biggest one. And I mentioned this. Yeah, sometimes if there's an indeterminate finding on a CT or an MRI, it could be helpful. Less so, though, I think, than in suspected recurrence. And disease response, again, can be useful, but not be recommended routinely for primary staging. So this is just another example. This is a patient with a rising CA125. They had a recurrence at their vaginal cuff, so in the left adnexa region, so where their ovary used to be, and their CA125 was rising. It was avid, so suggested there is cancer cells here. They started chemotherapy, and then we repeated them after 3 cycles, and unfortunately they still have, the mass is still there. It's still showing integral avidity, so it's metabolically active, so suggesting that this therapy may not be working. So that it's benefit. Okay, so finally, kind of when you have had surgery, you've had a complete systemic, you completed your systemic therapy, and it looks good that you have no signs of cancer and physical exam on your CA125 or imaging. So what next? How do we manage? Like, what's the recommendations of what we should do and how we should follow patients like you going forward? So from an imaging point of view, the recommendation, and this is from the NCCN, this is the Comprehensive Cancer Network, their recommendation is that we should only perform imaging as needed. I'll let Dr. Holcomb speak about this, but typically as needed means if there's this, clinically the gynecologist or gyne-oncologist suspects that you have recurrence. There is no role, and there's been no proven benefit of just routinely continuing on doing CTs into the future, because we probably won't, we're not very good at detecting it in that setting. So I'll let Dr. Holcomb speak about that further.
Yeah, I think this is an area where you're probably going to see, if you can go back to the last slide, you're probably going to see some variation in practice with the use of scans here. For those of you who had, for example, a useful biomarker, and I mean that you had an elevated serum tumor marker at the time of your diagnosis, for example, CA125 is actually very sensitive for the detection of recurrence. It may go up earlier than anything is even seen on a CT scan. So there are some patients who already have a marker that's more sensitive than the imaging, and so the repeated radiation exposure wouldn't help. I think the NCCN guidelines say to use imaging as needed, and what they mean by that is that we would be getting imaging to evaluate a new symptom. Physical examination is only but so helpful in that situation. Or sometimes the patient feels fine and they're just in for a routine visit, on one of those every 3 to 6 month visits, and you feel something on exam, even though they feel well. You may get imaging to try to figure out what that is, if it's clinically significant. And then a rising CA125 without any other explanation is commonly a reason why we'll be doing scans to see, is there any evidence of recurrence. So I think those are the 3 areas that are as needed. But like I said, there's a pretty wide variation in practice. There are some people who do routine imaging, although that's not what the NCCN is recommending, or the Society of Gynecologic Oncology for that matter. Next slide. So if you do have a recurrence of your cancer, because you had an elevated CA125 where symptoms occurred and this has been confirmed, we're typically going to treat again, and in most cases it's going to be systemic therapy. Some of the treatment consideration, when I say systemic, I mean it's something that's going in your vein and going all over the body, or in your, you're taking it orally, as opposed to a localized treatment like radiation, which we use much less often in ovarian cancer than other tumors. But some of the considerations we take into account as oncologists when that happens is how long has it been from your completion of your initial platinum-based therapy to the detection of this recurrence? And I'll show you some data to explain why that's important. We've got to take into account what kind of toxicities you might still have hanging around from that first line therapy. For example, if you were really unfortunate to have severe neuropathy that's already impacting your quality of life, giving you a second line therapy that also has a high rate of neuropathy should be avoided. The volume of disease at the time of relapse and is a marker for prognosis. And this serologic relapse is the term we use when somebody has an elevation of CA-125, and yet we see no evidence of disease on the CAT scan. And if any of you in the audience have ever been in that situation, you may have actually been recommended by your oncologist not to start treatment at that point. And that may have confused you to say, well, why not start treatment right away? And that's because there hasn't been a proven benefit to treating with a serologic relapse alone. Next slide. This is the data I was mentioning, that the disease-free or the platinum-free interval heavily impacts the likelihood that you'll respond to platinum-based chemotherapy again. Markman, Gore, Blackledge, these are all old studies, but they all showed the same thing. The longer from the time of your completion of chemotherapy to the detection of a recurrence, the higher the likelihood that platinum-based chemotherapy will work again. Next slide. This is showing the same thing. Next slide. So if you have a long progression-free survival, we're likely going to treat again with a platinum-based chemotherapy. Maybe you'll be offered platinum and Taxol again. Maybe you'll be offered platinum and Doxil, platinum gemcitabine. But if you have a short disease-free interval, typically less than 6 months between finishing your original therapy and then seeing this recurrence, the thought is that that tumor is so unlikely to respond to platinum-based therapy again that we really should be entertaining different options. And so that short disease-free interval will impact our decisions. Patients may have a poor performance status at that point. Mucinous or clear cell tumor types are less likely to be responsive to chemotherapy. Prognostic factors that also affect it would be high CA-125 and a large number of sites of disease. Next slide. I saw in the chat, someone said, I never heard of a repeat debulking. And a repeat debulking would be somebody who had treatment up front, had a recurrence, and now you're considering taking them back to the OR to try to remove the disease surgically again before going on to chemo. And up until fairly recently, there really wasn't a firm understanding of who benefits from an attempted repeat debulking. Next slide. But we have a much better idea now after this study. This was called Desktop 3. It was done in Europe. And what they did was they took this group of women who had pretty much the most favorable recurrences. These are women who had recurrences after 6 months of completing their therapy. It was their first recurrence. They had been completely debulked at their first surgery. And they randomized those women to either get a surgery again before going on to chemo, or no surgery and going straight to chemo. And as I mentioned, since they had progression-free survivals greater than 6 months, they were getting platinum-based chemo again, carboplatin, gemcitabine, Taxol, or Doxil. Next slide. And what this study showed, it was a large study, about 400 patients, they were able to completely debulk, and complete debulking means there's no gross residual, not even 1 centimeter residual, close to 70% of the patients. And again, these were women who had really good prognosis status coming into this recurrence. And there was an improvement in progression-free survival. And when you looked at how long did it take before you did another subsequent therapy, time to first subsequent therapy, there was a big difference. The women who had surgery was 21 months on average before they were getting another therapy after this treatment, and versus just over a year in the women who didn't get surgery. And so we do know that there's a group of women who benefit from a repeat debulking, and those same CAT scan findings that help us decide who to try to debulk upfront are useful in this situation as well. Next slide. Again, I already mentioned that we're going to be giving platinum-based chemotherapy for those with long disease-free intervals. Next slide. For platinum refractory or resistant patients, those who have a very short progression-free survival, there are a number of alternative chemotherapy regimens that you could give. Next slide. Weekly Taxol is often used, topotecan, etoposide, ifosfamide, tamoxifen, gemcitabine, Avastin. I want to bring your attention to that third bullet, Elahere. Elahere was just recently approved, and it is what's called an antibody drug conjugate. It's a monoclonal antibody attached to this chemotherapy. And it actually, it just came out yesterday that in a phase 3 study compared to using one of these chemos versus using Elahere, the women who got Elahere had an improved overall survival. And that was a targeted therapy because you have to have the tumor tested for something called tissue factor. And if they overexpress tissue factor, this is sort of a game changer and will be incorporated, I'm sure, into the treatment of drug-resistant disease. So it's a really good day for recurrent ovarian cancer as we start to introduce more treatment options that have actual survival benefits. Next slide.
So we're going to talk about some cases. In the interest of time, I might just skip the first two because they're just primary lesions and just talk about the third, which is a recurrent cancer case, because I think there's lots of questions and we want to leave some time for questions at the end. So, all right. Oh no, the last one didn't go in. Oh, if I can, sorry. I can pull it up. We could just do some questions. I can show it up at another time point if that's okay. Is that all right, Maggie?
Yes, that's fine. Well, thank you so much for, I feel like you've both covered a lot of ground, but we definitely have some questions. So let's get started with the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. So I'm just going to dive right in. Can any of the scans pick up diffuse ovarian cancer, often described as like rice or sand? So either one, feel free to jump in.
Yeah, I think one of the challenges in this disease is that is exactly that pattern of spread, that the rice that they're describing, we call it carcinomatosis. This sort of widespread, small little nodules that may coalesce into larger masses, but can actually have a pretty big volume spread out over a large area with each nodule being small. And the challenge is that the density of those tumor nodules is very similar to the density of the normal peritoneum next to it. And so I saw a question asking about, should you ever get a second opinion on a imaging? Is it a situation where the imaging is only as good as the person reading it? And I would say, yeah, to a certain degree, there are people who are better at evaluating these small changes that may be just areas of thickening, but are clinically significant. But I think it's a challenge, it's a limitation of the modality of CAT scanning. Dr. O'Dwyer, you have an opinion about that?
Yeah, I mean, like peritoneal disease can be difficult to pick up, especially when it's microscopic because of difficulties. So, occasionally PET can be helpful in that situation, but it's difficult when it's sub-centimeter. And often, especially in the primary staging setting, when we do tumor board, often the surgeon will say there was disease elsewhere, and we go back and look at the studies and we can't see it. It's just a limitation, unfortunately, of the disease. So that very microscopic disease is just challenging to find. So yeah, there's limitations within all these studies, but I think that's the value of working in a collaborative fashion with the gynec surgeons, our radiation oncologists, or pathologists, that we can hopefully, try improve our outcomes as much as possible.
Great.
I just want to say that I wanted to add one thing to the PET scan. I think in the days of this transparency, where a lot of you out there are probably getting access to your own reports for the first time and seeing them, through your portal, or if your PET scan is lighting up, and they're saying that we use that term hypermetabolism. If there's a focus of hypermetabolism somewhere, but there's nothing on the CAT scan correlating to it, it doesn't really help you much. And that happens often. You'll see areas lighting up, but then you look at the CAT scan portion and you can't see anything there. And so that's one of the limitations of PET.
Yeah, I mean, unfortunately, PET is also a limitation itself, because FDG PET, which we use for ovarian cancer, is looking at glucose metabolism, but glucose is also metabolized by inflammatory processes, infectious processes. So it's sensitive, but it's not specific. So hopefully in the future, especially with this new drug coming out, potentially we can target specifically for certain integral expressed things within the cancer. That's happened in prostate cancer. Some of the audience might be aware of that with PSMA. And that's been a real game changer for prostate cancer. And I just do PET specifically looking at PSMA. So, in the future, we can find a single target for ovarian cancer, or even for a subset of our ovarian cancers. It would be helpful and be a little bit more sensitive and specific in these patients, and could potentially be a useful imaging marker.
Great, thank you. And Dr. Holcomb, you actually started to address what was going to be my next question, but essentially whether there are any instances and whether getting a second opinion on imaging tests would be helpful.
Yeah, I think, like anything else, people who do things on a high volume and have a lot of experience are better at it. And I think, if I was having a CAT scan read especially with carcinomatosis, I would want to have it read by somebody like Dr. O'Dwyer, who is looking at a high density of these every week. So there may be a time. Obviously, what you do with that information, how a clinician interprets the scan and what they recommend can be very different as well. So, when you go to get a second opinion, you're really getting a second opinion on every level. Your slides should be reviewed. There should be a pathology second opinion. Your radiology should be reviewed. There should be a radiology, and then you're getting an opinion of a surgeon or a clinician as far as what they would do with that information.
Great. And then does the recommended imaging ever have anything to do with the ovarian subtype? So for clear cell or low grade serous, for example, are there maybe different recommendations for scans, or is it it doesn't really matter?
Well, it matters that it's important that we know what type of cancer it is, because they can act and have different appearances. So clear cell or mucinous type can look more cystic. So they won't have a solid mass appearance. So if we're looking for things like peritoneal disease, may appear very differently. So it's not so much that we would recommend different things, they may look differently, and it's important for us to have that information. As I touched briefly on in the talk, PET-CT often isn't very helpful in that situation, because they're predominantly mucin. They're not very high in cells. They don't have a lot of solid cells that consume the glucose. They often aren't very avid. So it often isn't very helpful in a mucinous setting compared to a serous or even low grade, because it's a lower grade. Again, it may not have a lot of cells that consume the glucose, so PET may not be useful in that setting.
Great, thank you. And then I know that this was touched on a little bit, but I'm wondering if you could talk, elaborate more on, some of the risks associated with the various scans, especially when patients are getting them regularly, and how they could mitigate some of those risks.
So CT is generally very safe. It does have a radiation dose attached to it, but it's about 4 times the background radiation that you have by just living your life. So this background radiation just from radon gas, different things, going on a flight, like a long haul flight, you have a lot of radiation. Up a transatlantic flight, you get a lot of radiation with that. So the dose was something that we were more concerned about in the 90s when we first CT became more available, because the image parameters were giving a much higher radiation dose. And then we saw the issues about that and the frequency it came back, and we've really pulled back on our dose. We do it with techniques that are much less than they were back in when those initial kind of issues about and concerns were about multiple radiation. Having said that, we're trying to limit overexposure, and we're trying to make sure that we're only doing tests when they need to. But overall, for patients with ovarian cancer, if you're being suggested you have a CT, it's a justified indication, and I don't think that people should worry too much about the potential risks of secondary cancers, which is what we worry about. The doses are very low, the long-term longevity, it's basically a risk-benefit analysis that we have to work out as radiologists and as referrers, to be like, is not doing the scan going to be a greater risk than potential risk of them developing a cancer in 20 years time? And in a patient who has a known ovarian cancer, I think that's a pretty easy question for us to answer. I just saw in the chat there people asking about contrast. Contrast is super important for us because it really helps us pick up smaller disease. So it makes it easier to pick up peritoneal disease, sub-centimeter metastasis in the liver. So it's really, I think if you're recommended to have a contrast enhanced CT, it's really, we should try do it unless there's a serious contraindication why you shouldn't do it, that you have very poor renal function or kidney function, or you have a true allergic reaction that isn't safe for you to have the contrast. So the contrast we use for CT is iodinated contrast. That is not the same contrast that we use for MRI. MRI, we use a contrast called gadolinium. And again, that's relatively safe. There is a small subset of the population with very poor renal function who we don't like to use it in. And there is a potential risk if you're getting 20 MRIs in your lifetime, that you would potentially, there may be some deposition in places like the brain, which people may have read about, but that for this population, they're not getting that amount. That's bigger probably issue and concern in patients with multiple sclerosis who are getting multiple studies over and over again. So again, we just have to be mindful of that. So they're not the same. The allergies aren't combined. They're not the same. They're not this. So just because you have an allergy to iodinated contrast does not mean you have an allergy to gadolinium contrast. So it's complicated. And then for PET CT, we give people oral contrast. We do not do it routinely with IV contrast. There is some institutions that do it, but they're doing basically a diagnostic CT at the time, and they're doing a PET CT at the same time, but routinely we don't give that. And for oral contrast, you don't need to be worried about renal function, allergy, things like that. It's a different entity. It's complicated.
Oh, great. Thank you for explaining that. And so I'm looking at the time, and unfortunately we're at time, but I was hoping we could wrap it up with maybe each of you sharing, your takeaway from this conversation that you want our audience today to have in terms of scans and ovarian cancer.
Sure. I would say my philosophy about scans and really all diagnostic tests during your journey is that I only want to do scans that are going to help me make decisions that are impactful. I don't want to do scans that I'm not going to use the information. And so, I try to be very thoughtful about what situations are where it's going to play a role. And then I work closely with my colleagues like Dr. O'Dwyer. We see each other every week in tumor board. We work on a disease management team. And often it's a conversation. That's the benefit of multidisciplinary care, to try to answer what's the best test for this person to answer the question that's usable information at that moment.
Great. Thank you, Dr. Holcomb.
And similarly, we don't want to be doing scans and causing confusion. So it's important that things are done when they're indicated, and that we would try to offer the most amount useful information, because I don't work in unity, and none of us work in isolation. We all work together. So, and our main aim is just try to give clear information that offers the best information, that offers guidance about how treatment should be performed. So, we could do it. You could do a test every day of the week, but is it going to offer a huge amount of information that's not helpful? Then that's we have to think about that. And then it's important for us just to be working with our colleagues, reading clinical notes, because this is sometimes quite nuanced, especially when patients are on therapies. We are on multiple different therapies. They might be getting radiation to one site, chemotherapies, targeted therapies. So it's important that we're just kind of clear about what's going on, and it's complex. So And you know, it's much easier probably 20 years ago when it was like one line of chemotherapy and where there wasn't that much imaging. So it's, you know, it is nuanced and it's not easy to understand. So I can understand why patients are confused about it. But, you know, there's a lot of clinicians who don't even understand it. So it is important just to ask questions, and we're always, as radiologists, happy to answer questions. Or if you speak to the your gynecologist, your gyn-onc, or your oncologist, then we're happy to liaise with them. And, you know, we're trying to improve awareness overall and answer questions, because that's things better for everyone overall.
Great. Thank you so much, Dr. Holcomb and Dr. O'Dwyer, for providing this extremely informative program. You know, I think you answered a lot of questions and helped provide clarity on this topic. And thanks to all of you for participating and submitting all of your great questions.
Yes,
we
I have
really
to say,
appreciate
Maggie,
it.
there's so many excellent questions I see in the chat that we didn't get to. It's
I know it's tough.
the care community always keeps you on your toes. Excellent questions. I wish we had more time.
I know I mean, the questions are great. People, you know, our community knows a lot. So, but, you know, make sure to check out all of Share's upcoming educational programs and support groups, and follow us on social media as well. You'll see we have a report back from SGO coming up, so definitely register for that. And please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. So thank you, everyone. That concludes today's webinar.
Have a good night.
Thank you.
Thank you.